everyone. Ready? Is it too loud? It feels really loud. All right, everyone, I think we're going to go ahead and get started. If we could find our way back to our seats. We've got 2 more presentations before lunch. You can. Okay. All right. So we got 2 more presentations before lunch. So we'll go ahead and get started. I'm hoping you can hear me okay. A little. Okay. So hi, everyone. My name is Jenny Winkler. I'm a Director of Quality, Safety, and Health Policy at the Illinois Health and Hospital Association. So glad to be with all of you today. We've had some really great speakers starting off this morning, and so I have the privilege to introduce the next 2 speakers. So I want to start by introducing you to Dr. Jason Pogue. Dr. Pogue is a clinical professor in the Department of Clinical Pharmacy at the University of Michigan College of Pharmacy, as well as an infectious disease clinical pharmacist at Michigan Medicine. So Dr. Pogue is a recognized leader in regards to antimicrobial stewardship, which is evidenced by his contribution to more than 125 peer-reviewed articles, more than 125 abstracts, multiple book chapters, and presentations at national and international conferences. So we are so excited to have you with us today, Dr. Pogue. I will turn it over to you.
Thank you. If that sounded like a nice introduction, it is because I wrote it. So that's the beauty of this, right? So thank you so much to the DOH for having me out here. Again, there's a lot of qualified people in this state that could do this. So to have me down here, I really do appreciate it. And I have to be honest, I would never have known Bloomington, Illinois was a place had it not been here. I was a foolish Michigander who thought it was only in Indiana. So this was a very educational thing to me. So thank you for having me here. It's a privilege. This is a topic that is always fun to talk about, the top papers in the last year or so. And we'll get to that in a second. But before we do, I want to start off with disclosures. I do think it's important to give these disclosures for transparency's sake. So I do a lot of consulting in the gram-negative resistance space. I also have some grant support. But interestingly enough, I have a new conflict of interest to tell you. So my wife, she's definitely the better half of this relationship. She's a cardiology pharmacist. She spent 15 years at the University of Michigan, and she just recently took a job for Merck as a medical science director. So again, new conflict. So I'm going to give you that for transparency. It's completely irrelevant to this presentation, but I like to be transparent. For those of you that know Merck, you could give, they have 2 antibiotics in the gram-negative space. You could give it to every single patient at your hospital right now, and that's not going to touch Keytruda. So I don't think that's a real conflict that we need to be worried about, but I like to be transparent, so I'm going to give that to you. And so again, I was given this really broad topic, right? Give us the top papers in stewardship from about an 18-month time frame. And oh, by the way, you got 25 minutes to do it. Very realistic thing to do. And so I sat and I thought, okay, how do you want to attack this, Jason? So the first thing I had to do was say, what am I not going to talk about? So first and foremost, no COVID. I don't want to talk about COVID. Yes, you can cheer. I don't want to talk about it. You don't want to hear about it. Let's move past that. So secondly, we're not going to talk about penicillin allergy. Now, to be honest, this is a critically important stewardship intervention. And I will tell you that penicillin allergy reconciliation is probably in my top 5 things of things you should be doing in your stewardship program. Optimize outcomes of your patients, decrease those other antibiotics that we use otherwise. However, I would make the argument that it's well established at this point in time that we should be doing it. And to be honest, there's probably 15 papers that have come out in the 3 minutes that I've been speaking so far on this topic. So really impossible to go down that route. So that's out. And then the third thing we're not going to talk about, and I might lose my pharmacist card because of this, but we are not talking about vancomycin. Talk about things I am sick of talking about. I've been practicing for 15 years, and I think this is every single presentation I've ever given. Not saying it's not important. Dose optimize this. Save your patients' kidneys. But the best advice I can give you with regards to vancomycin is don't use it. Use other drugs. They're generic now. There's no longer any excuse. Get off of this drug. We're not going to talk about it. Okay. So with that, Now that we talked about what I'm not going to discuss, I had to figure out, and especially when I just used 5 of my minutes, right, on that long introduction, is what am I going to talk about? So whenever I give a stewardship talk, I always like to be grounded in what are the goals of stewardship. And I think we always need to remember that our primary focus is optimizing patient outcomes. How do we do that? Right drug, right dose, right route, right duration. And so what I want to do today is I want to pick one paper on each of these topics to focus on today. And my goal is to give you stuff that I think should be practice changing for you. And I want you to take back to your institution. Again, you don't have to do these things just because I said so. I'm not that special and you shouldn't do that. But I want to present to you these data and I want you to have this conversation back at your institution because I think we can optimize patient outcomes based off of some really high impact publications that have recently come out. Okay, so antimicrobial stewardship. So what drug am I going to talk about? Not even an antimicrobial. We're talking anti-inflammatory immunomodulatory therapy, but this is a practice-changing clinical trial that came out just a few months ago in the New England Journal. You know when an ID article is in the New England Journal of Medicine and it's not related to COVID, that's a big deal. So this is the Cape Cod trial. Cape Cod stands for community-acquired pneumonia, and then part of the COD is related to corticosteroids. Has nothing to do with a quaint little town outside of Boston. It's just a clever acronym for their clinical trial. And if that sounds familiar to some of you stewards that are in the audience and it's giving you some like weird flashbacks, it's because this study, interestingly enough, this study took place from 2016 to 2020. It was powered to enroll 1,200 patients with 2 interim analyses at 400 patients and 800 patients. In January of 2020, they met their second interim analysis, and then something happened, right? Something changed, particularly in the pneumonia presenting from the community space at that time that made them shift this. So they basically abandoned this and actually enrolled patients into a similar study for COVID-19. And so if you actually look, in addition to the recovery publication, which was the big game changer for steroids, the data from this group from 31 ICUs in France are also there as well. And so as they moved forward, you know, the steroid question kind of got settled in COVID-19. They moved into 2021. Remember, the winter of 2020 into 2021 was particularly nasty with regards to COVID, so they were overwhelmed. Then Delta happened. And then after Delta, things started to settle down in these French ICUs. No longer were people in France pushing hydroxychloroquine, right? They could focus on things that actually matter for patients. And so they're like, let's revisit this trial. So DSMB, do that second interim analysis. Guess what? They stopped it early for efficacy when they finally did that second interim analysis 18 months after they would have originally. And so very interesting background story here to this study. So we're deprived of knowing about this study by about 18 months because of COVID. So another thing that you could blame COVID for. And so again, this is looking at hydrocortisone in patients. So looking at corticosteroids for patients who have severe community-acquired pneumonia. This has been a long controversial area in infectious diseases. You can see there that they enrolled patients with severe community-acquired pneumonia. You can see the definitions there. I won't read them to you, but the bottom line is that these were sick patients. So again, you're looking at patients who needed either invasive or non-invasive mechanical ventilation. They had needed high flow nasal cannula. And again, I know I'm giving you COVID-19 nightmare flashbacks when I say words like high flow nasal cannula, which nicely wasn't in my vernacular 3 years ago. But again, they were sick patients requiring a lot of oxygen support. And one of the beauties of this study, and why I really like this study, is note the blue over on the right side of the screen. They got patients enrolled within 24 hours of presentation. And we've learned that the timing of these types of interventions are really important. And if you actually look at the publication, on average, it was 15 hours from presentation at the ICU that they got them enrolled. So really well done in this trial in France. The 2 arms were hydrocortisone as a continuous infusion compared to matching saline placebo. And the duration of therapy, you'll see that 4 days there with an asterisk. Essentially what happened was at day 4, they assessed the clinical status of the patient. And depending on how they were doing, they either tapered them off to a total duration of 8 days, or they gave a little bit longer course and then tapered to 14. So the duration of therapy in the study was actually 8 to 14 days. So it's important to note if you're going to apply these to your patients. However, they also had a rule in the protocol that said if patients leave the unit, so obviously they've responded, right? They're out of the ICU, they stopped therapy. So actually on average, patients got 5 days of therapy in the study. But again, the question they were asking is, could they improve outcomes in patients with severe community-acquired pneumonia? So anytime you look at one of these publications, you should always look at the study population to see how like your patients they are. And what you'll see is this was a sick population. Average age was over 65. About a third of the patients were female. But as you can see there below, about 90% of patients in the study either required invasive mechanical ventilation, non-invasive, or high flow nasal cannula. So these were sick patients. And if you look at the pneumonia severity index, which is just a severity system for community-acquired pneumonia, all I want you to see is that most patients were stage 4 or 5. The higher, the worse. And those are the highest two that exist. And so you'll see there. And then just at the bottom, there's a severity of illness marker. That's a SAPS-2 score. That number is associated with probably about a 15 to 20% expected rate of mortality. So bottom line is these were patients with community-acquired pneumonia, and they were legit sick. So what happened when they finally did that second interim analysis? Why did they stop it? Well, it's that first thing that you see on that would be your left side of the screen there. 28-day mortality almost halved with the addition of hydrocortisone. So almost a 50% reduction. You can see that's statistically significant. That held true out to 90 days. And if you're into number needed to treat, which I always like, that's 18 patients. So treat 18 patients with severe community-acquired pneumonia, save 1 life. That's a hugely successful intervention. Now, maybe that's a little overblown because they stopped the study early, and maybe that messed with the confidence interval a little bit, but still a hugely impactful intervention. But that's not the only thing that they looked at. And again, I'm going to give you nasty COVID flashbacks again. But again, think about all of these studies that you look at, the progression of disease, right? Those who weren't intubated, how many needed intubated? Those who weren't mechanically ventilated, how many needed it? Those that weren't on pressors, how many needed it? What you found was for every single one of those outcomes, you saw about a 30 to 40% relative reduction. Huge impact in this study. But the question is, the reason we just don't give steroids to everyone is that people always wonder, is it safe? Right? There's side effects. And so they looked at that. The most notable one we concern ourselves with is usually secondary bacterial infections. And what they showed was no difference between the two groups. They looked at GI bleed, no difference between the two groups, and actually happened to a very small proportion of patients in the study. The only thing that was different, and not surprisingly, because you were giving steroids, is that because they can cause hyperglycemia. So there were more patients who required insulin, and the amount of insulin they required was higher. But you know what? I think that's a pretty fair trade-off to be alive. So again, I find this to be very impactful, very practice changing. I want you to talk about this and think about it at your institution. I know my intensivists that are here are going to say, yeah, Jason, but hydrocortisone is on severe shortage. Of course it is, because that's the life we live. So we might not be doing this immediately, but this is something to look at moving forward. And again, this needs to be kind of positioned in the whole spectrum of corticosteroid literature, because there's also a smaller RCT that's out there to look at methylprednisolone that they did not show a benefit. And so again, it's important that, in my opinion, I think the data support hydrocortisone and only hydrocortisone for the treatment in these patients. And as we know, steroids can differ with regards to their mineralocorticoid or their glucocorticoid components. And so I think you really, to follow the evidence, it would support using hydrocortisone. So have that discussion at home. So that's drug. Let's talk about dose. And this is an area that's very near and dear to my heart. These are actually data from our group when I was in Detroit, and that's extended infusion beta-lactams. And so if you've ever heard me talk before, or heard me ramble before, which might be a better way of putting it, I am a huge proponent of maximum dose extended infusion of beta-lactams for every single patient that you're treating with a beta-lactam when you're giving an anti-pseudomonal drug. The reason is because that pharmacodynamically optimizes the drug and it's safe. So those two things going together, it's a really nice dose optimization. So much so that we implemented that in 2013 at the Detroit Medical Center, hospital-wide. And then the other reason I want to talk about this publication is because of the first author. So Nikki Tran was my PGY1 resident. So for those of you that are trainees, you can do these types of things as residents, even when your preceptors are mean and push you to really do that. And so she actually completely did this study. She wanted to look at whether or not this improved outcomes in patients. And so just so you know, she reviewed over 7,000 charts to find her patient population. So she deserves all the props in the world. She's now at Ohio State, so congratulate her when you see her, even though we'll forgive her for being at Ohio State now. But so anyway, what we wanted to do and what she was doing, she said, okay, let's take a disease state, gram-negative bloodstream infections, and see if extended infusions improved outcomes in patients. And so that was the study design as you see here. So what we did is we compared outcomes of patients who got extended infusion of cefepime, piptazo, or meropenem to those that got intermittent infusion. And because there could be some differences, and this is why Nikki had, because she had a mean preceptor, she had to go through 7,000 charts, is because we wanted to control for differences in this study. And Nikki was really adamant that she wanted to make sure that the intervention was the driver. So she matched patients one-to-one based off of severity of illness. So did they have severe sepsis or septic shock? Were they in the ICU? Yes, no. The source of the bacteremia, was it a urinary source or another source? And then the infecting pathogen, was it Pseudomonas or an Enterobacterales? She also matched, I don't know why I don't have it on this slide, but she also matched based off of study drug. So cefepime for cefepime, piptase for piptase, marrow for marrow. And what you'll find is she did a really good job of matching patients. So if you look at the population, you can see about 40% of them were in the ICU or had severe sepsis or septic shock. If you're curious about the source of infection, about half of them were urinary in nature. And one thing I want particularly our stewards in the audience to see is look at the microbiology breakdown. Only about 10% of patients had Pseudomonas. That's not surprising because it's a gram-negative bloodstream infection study. But I think that's important because when you talk about organisms like E. coli and Klebsiella, when they're susceptible to drugs like cefepime, meropenem, and piptazo, those MICs are really low. So you should get good exposures even with intermittent infusions of these drugs. We just hypothesized that you could do even better with extended infusions. And so if you look at that, they both groups got max dose. And so really the only big difference was that extended infusion. So the hypothesis that Nikki had was that since we're pharmacodynamically optimizing, but we're still treating patients in both groups good, we're hypothesizing that patients will get better faster. So the primary outcome in this study was actually time to resolution. And for each of those that you see listed on the screen, patients got better about a day faster if they got extended infusion of beta-lactams. And that actually ended up having an impact on length of stay, on recurrence rates, and on treatment failure, the need to escalate. So you saw pretty much across the board. It did not have a benefit on mortality because only 4 patients in the entire cohort died because, again, we treated them well in both groups, but we did get patients better faster. And one of the things that's really important and I think interesting about this publication is that, again, Nikki wanted to dive in deep. And so she wanted to make sure that baseline renal function wasn't driving it, or ICU status, or what the bug was, or what the source of infection was. And basically in every single subgroup, you saw completely consistent results. And so really these results held true across the board. So I would encourage you to take a look at this publication and consider whether or not you can further dose optimize beta-lactams at your institution if you're not currently doing it. So that's drug. That's dose. Let's talk about route. So route didn't have a lot of good publications this year. Not a lot of excitement. I didn't have a good inhaled study to bring up. And so I wanted to talk about oral antibiotics, which is kind of boring. IV to PO is kind of a stewardship staple of the last 30 years. So it's not the most exciting topic, but we know that IV to PO switch is a good thing, right? Again, you can see that very happy mannequin that's on the screen right now getting his fake oral medications. He's thrilled. Why is he so excited? Because he's going to get out of the hospital faster. He's going to have less complications like thrombophlebitis or a line infection. It's going to be cheaper. and he's just going to be a happy camper, right? This is a staple. And one of the big pushes in stewardship is that we're actually pushing to, even in serious infections, if we can optimize the math, getting patients over to oral therapy. And I will actually just say that my friend and colleague, Dr. Cynthia Nguyen, is actually going to be talking about that this afternoon. So if you want, I'm not going to get into all that nerd details. She will. And I encourage you to take a listen to that if you're interested in that topic. But again, bottom line is we push orals in patients. But despite that, and this is actually an interesting study that I chose just based off of the conversation that I heard in the break we just had, you might still need to convince people, right? They might still want IV because they're stronger, they're better. It's not something that the administration prioritizes. And so what I want to actually share with you, this isn't a publication. This was actually a presentation. This was a platform presentation at ECCMID, which is the International ID meeting. And this was led by a pharmacist in the UK. And you can tell it is because it's called jabs to tabs, right? They love the word jabs in the United Kingdom. But basically what she wanted to do and what the investigators wanted to do in this study is they wanted to actually quantify the amount of time that was spent. I know I have a nursing audience here, so you're going to really appreciate this study. They wanted to quantify the difference in the amount of time spent in everything that went into an IV medication. So again, making it, verifying the patient, hanging it, giving it, removing it, double checking it, all of those things that go into that, and compare that to what it was like to just give patient an oral medication. And what they found was that on average, nurses spent 22 minutes per dose of their time for an IV medication compared to 1.5 minutes with oral. And if you do the math, if a drug is given 3 times a day, that one drug is 1 hour of nursing time. And so then what the investigators did, which I thought was just fantastic, is they said, I want to show you what this actually means. So they had a giant hospital, a 2,200 bed hospital. So you might have to scale this appropriately to your institutions. But she just did a point prevalence study. She said, how many patients are on IV antibiotics in my hospital today? 528 patients who got 1,634, yep, that's the right number, 1,634 doses. You times that 1,600 number by 22 minutes, and you are talking about 540 hours of nursing time that is spent on IV antibiotic administration. And what they actually said in the presentation, it's a brilliant platform presentation. She was like, let's say we could convert 10% of that to oral. And my stewards in the audience knows that's a really conservative amount. We could probably do a lot more than 10%. But 10% of that is 54 hours of nursing time. Again, even 12-hour shifts, that's 4.5 nurses. So if you need something to push for resources or that this is important, this is another angle to attack this. And I really like this study because it looked at it a little bit differently. And then last, but certainly not least, is the duration piece. And this is actually a little bit more than duration. This was a partnership that was done with Henry Ford Hospital, which is in Detroit. So for those of you that don't know, which is probably most of you, the main campus, the academic center for Henry Ford is in Detroit proper. And then in the community, they have a bunch of community hospitals. They actually did this intervention both at the academic center as well as the surrounding community hospitals. So this was a partnership with the CDC. And so what they were doing in this study is they wanted to optimize transitions of care, discharge oral antibiotics. We know this is a huge area in need of improved management because what we've learned over the last few years is that when patients go, they get a full course once they leave. On average, they get 3-4 days more antibiotics than they get. So what they wanted to do is they wanted to have a pharmacist-led intervention, and this was both stewardship pharmacists and clinical pharmacists as a whole, that were basically looking to optimize that prescription at the time of discharge. So again, duration was a big piece of that, but they also looked, did they need the antibiotic? Is the dose right? Is the agent right? And so what's really nice, I don't have time to get into all of the intricacies of this study, just because again, I got 30 minutes that I'm already at, right? So I don't have the time to get into the intricacies of the study, but I encourage you to take a look at it because they did a brilliant job in partnership with the CDC of really tailoring the intervention to the different floors in hospitals based off of the resources that were there. So if they had a rounding pharmacist, it was on rounds. But if they didn't, then there was a process that was set up there. They engaged the nurse managers. They actually engaged the outpatient pharmacist as well, that if there was a discharge prescription for oral antibiotics where a pharmacist hadn't written a note saying that this was the right thing to do, they would actually call. And so they engaged every piece of that story to try to improve the management on discharge of respiratory tract infections, UTIs, skin infections, and intra-abdominal infections. And what you'll find is that they were grossly successful in doing this. Yeah, you thought I was going to say gross in a bad way, but it was actually in a very good way. They were very successful at doing this. On the left side of the screen is where they started. So at the beginning of this, 20 to 50% of patients were discharged on optimal oral antibiotic regimens, being the right drug, dose, and duration. By the end of the study, this approached 80%. They saw a 40% absolute improvement in optimal antibiotic use at discharge. And what I think is really important, because they tailored those interventions to the resources, they found it at both the academic center and the community hospital. So this can be spread out along the line. And then finally, they also looked at hard outcomes. So they wanted to first off make sure they weren't hurting people. And they showed that, mortality was the same, cure rate were the same. But what's really interesting is that they showed these numerical and in some situations statistical benefits with regards to readmission rate with that intervention, as well with isolation of MDROs down the road. And so again, these are kind of confounded outcomes in my opinion, because a lot of stuff goes into that, but at least a suggestion of not only no harm, not only did we give more optimal antibiotics, but we seem to have decreased some of the bad that comes with antibiotics as well. And so just to wrap up, this is worth your time. Again, it's individualized to the resources that you have there, and Henry Ford has done a phenomenal job of giving you the blueprint of how to do that, so you can run with that at your institution. And one thing that I think is really interesting about these data that should maybe even encourage you more to bring this home and look at it is that they showed all these benefits in the setting where they weren't doing too bad to begin with. Their duration of therapy that they changed was only like 1 or 2 days. And so they weren't huge impacts. If you're anything like the institutions that I've practiced at, your discharge antibiotics are way worse than this. And they were showing potential improvement in these hard outcomes, even with these relatively modest decreases in duration of therapy. And that could even have a bigger effect at your institution. And so with that, that was my rapid drug dose, route, and duration. I thank you again for having me so much. It's a privilege to be here.